insight that through this light I find the reason why, that I may have the knowledge to provide. All these I ask of you, Lord, that through my hands I mend the injury, touch it, heal it, hold it tenderly, that I may be an instrument to thee. Guide me, I ask of you, Lord. When I doubt in times of trouble, and I feel the need to cry, Lord, remind me of your image as I journey through the night. Let your name be glorified. Oh, that through your eyes I see no pain inside. That through your light I see no reasons why, that I may have the love to provide. Touch me, heal me, mend me, hold me. All these I ask of you, Lord.
Good afternoon. Each year, WHO and
Good afternoon.
Good afternoon. Each year, WHO and the international community commemorate. Good afternoon. Good afternoon. Each year, WHO and the international community commemorate World TB Day to raise public awareness about the devastating health, social, and economic consequences of tuberculosis or TB, and to step up efforts to end the global TB epidemic. The Philippines is the second highest per capita burden of tuberculosis in the world, and WHO supports the Department of Health, Disease Prevention and Control Bureau, or the DOHDPCB, to end TB by year 2030. This support follows a cascade of care, screening, testing, treatment, and prevention. World TB Day is an opportunity to focus on the people affected by this disease and to call for accelerated action to end TB suffering and deaths, especially in the midst of the ongoing COVID-19 crisis. Today, the Philippine College of Radiology, or PCR, joins in this event and shows its support in the campaign to stop TB. In celebration of the World TB Day 2022, the PCR, in partnership with the Philippine Thoracic and Cardiovascular Radiology Society and the Philippine Coalition Against Tuberculosis, or PhilCat, invites you to join us this afternoon in the webinar entitled PCR Connect and the World Tuberculosis Day 2022, a radiology in action from diagnostics to therapeutics. Welcome to PCR Connect and happy learning. And now, I give the virtual stage to our moderator this afternoon, Dr. Ana Marie Agabao.
The Philippine College of Radiology joins the world in celebrating the World TB Day with the theme PCR Connect the World and Contribute in Flattening the Curve through Solidarity. The Philippine Thoracic and Cardiovascular Radiologic Society invites two non-radiologists from the specialty group to give us a 30 minutes lecture, Radiology in Action from Diagnostic to Therapeutic. Can I share? Screen share. Our first lecturer is regarding diagnostic imaging in tuberculosis. He is a fellow of the College of Radiology. He took his Doctor of Medicine in Iloilo Doctors of Medicine. He had his training at radiology residency training at Philippine Heart Center. He also had her fellowship training in general ultrasound at Lung Center. She took his fellowship training in CT MRI at Philippine Heart Center. Friends, may I present Dr. Mary Grace Vargas. Hindi ko siya marinig.
Afternoon. Today, I'm going to talk about Good afternoon. Today, I'm going to talk about the ever mainstay major global health issue affecting all countries and age groups, pulmonary tuberculosis or PTB. According to the WHO, TB remains in the top 10 causes of death worldwide. In the past years, there was a decrease in the number of cases through the effort of the World Health Organization. However, there is a raise of concern of possible reversal of the regression due to the delayed diagnosis brought about by COVID-19. The aim of this lecture is to review the old, the new, and the borrowed findings of TB as to improve our understanding of the diagnostic value of imaging. Here are the key points of this lecture. Radiologic findings are crucial in the diagnosis of active pulmonary tuberculosis. Immune status affects the radiologic presentation of Ptb. The great mimic, Ptb, may mimic imaging presentations of other diseases, and certain imaging features on CT correlate with sputum smear positivity. In this lecture, we will review the pathophysiology of primary TB as well as the old and well-established TB findings. Then, we will also discuss the unusual, or should I say, borrowed appearances of Ptb. Usually, these are the common features of other diseases. And lastly, we will talk about the radiologic features that correlate with sputum smear positivity. Now, we proceed to the discussion of the classification of Ptb infection. Pulmonary tuberculosis can be classified as the primary TB and post-primary TB. These classifications are considered as distinct entities based on their clinical, pathologic, and imaging features. Tuberculosis is classified as primary if the disease onset occurs within 1 year from the initial infection with Mycobacterium tuberculosis. It is most prevalent in infants and children with the highest disease occurrence under 5 years of age. On the other hand, pulmonary tuberculosis is classified as post-primary and is designated as reactivation if onset of disease is more than 1 year after initial infection. Reinfection also falls under post-primary TB and occurs when there is infection within a different strain, especially in endemic areas. Post-primary TB, by definition, occurs in patients who are already sensitized to Mycobacterium tuberculosis. Thus, it is considered a disease of adolescence and adulthood. Primary and post-primary tuberculosis present with distinctive imaging features. Primary TB classically presents with dense, homogeneous consolidation with lower and middle lobe predominance, lymphadenopathy, miliary disease, and pleural effusion. On the other hand, post-primary TB presents as centrilobular nodules, tree-in-bud pattern, consolidations, ground glass opacities, cavitations, bronchial wall thickening, miliary nodules, an isolated pulmonary nodule, parenchymal bands, and interlobular septal thickening. Studies on the pathophysiology of primary TB found that infection begins with inhalation of 2 to 10 micron droplets laden with bacilli from an infected host. The mycobacteria then reach the pulmonary alveoli, preferentially in the best ventilated areas of the lungs, where they invade and replicate within the alveolar macrophages. Development of granuloma then ensues, which may progress to a larger tuberculomas. 4 to 10 weeks after initial infection, patients then test positive during tuberculin testing once delayed hypersensitivity develops. At this stage, a pulmonary focus forms which is called the Gons focus. Caseous necrosis occurs within the Gons focus and the involved lymph nodes. The combination of the Gons focus and the involved lymph nodes are what we call the Gons or Rathke's complex. If the Gons focus is healed, it undergoes scarring with and without calcifications, which may be visible on imaging However, in some cases, the goal's focus may enlarge over time. The mode of disease progression determines the radiologic manifestation of TB. Local progression manifests as consolidation and cavitation, while bronchogenic dissemination results to centrilobular and 3-in-bud nodularity, while hematogenous spread causes miliary nodules. Lymphatic spread also yields characteristic imaging findings, which will be discussed later. Here are some images to illustrate how TB progresses. In the first image, we can see that it can form cavitations in the lungs. In the second image, we see tiny nodules diffusely scattered in both lungs. The third image shows chest X-ray and the CT scan showing nodularities in 3-in-bud appearances. And lastly, we show that post-primary tuberculosis can spread via lymphatics and present as an enlarged lymph nodes. Studies in molecular epidemiology in the 1990s have shown that imaging features are not only necessarily determined by the time since infection, but rather the age of the patient and immune status. Lower lobe disease, adenopathy, and pleural effusions are common in children and immunocompromised patients, but are less typically seen in immunocompetent adults. On the other hand, the imaging of upper lobe cavitary disease are usually seen in reactivation and in immunocompetent patients. The following are the different imaging findings typically seen in TB. Tuberculomas are nodules seen in TB patients, sometimes seen to be the only imaging findings in up to 5% of patients with active disease. Satellite nodules are typically located adjacent to the tuberculoma with smooth, well-defined margins seen in approximately 80% of TB patients. A solitary tuberculoma may pose a dilemma to the radiologist since it may be mistaken for a malignant process. Patchy, ill-defined, heterogeneous consolidations may represent the first radiologic findings in active TB. Involvement is usually seen in the apical and posterior segments of the upper lobes and the superior segments of the lower lobes. More than one pulmonary segment is involved in many cases. In the absence of other features, such as lymphadenopathy, cavitations, or clinical history of poor response to antibiotics, consolidation due to Ptb may be challenging to distinguish from bacterial pneumonia. These lesions usually liquefy and form cavities when the contents are drained through the tracheobronchial tree. Cavitary changes may be seen in as much as 50% of patients, which are usually multiple in numbers with thick, irregular walls. Following proper antimycobacterial treatment, the walls of the cavities may become smooth and thin. The presence of air fluid levels within the cavitations suggests superinfection. As mentioned earlier, bronchogenic dissemination results to multiple 2 to 4 mm centrilobular nodules with linear branching opacities, described as a 3-in-bud configuration. These lesions may coalesce in a segmental or lobal distribution, primarily seen in the lower lobes and in the periphery of tuberculous consolidation or cavities. These micronodules are difficult to appreciate on chest X-ray, thus CT scan is preferable in investigating the presence of early bronchogenic dissemination. Although the 3-in-bud sign was initially described as a distinctive presentation of endobronchial spread of TB, it is not pathognomonic for active TB. Involvement of the central airways manifests as circumferential wall thickening with luminal narrowing. Bronchial stenosis may be present in approximately 10 to 40% of patients with active TB, which can result to segmental or lobar atelectasis, lobar hyperinflation, mucoid impaction, and post-obstructive pneumonia. Miliary TB is seen in cases of hematogenous spread of TB as 1 to 4 millimeter nodules of uniform size with a random distribution, but with slight lower lobe predominance. Intra and interlobular septal thickening may also be seen. These tiny nodules can be detected by CT imaging even before they are seen on chest X-ray. Miliary TB has been reported to be associated with infection in the pediatric patient or in immunocompromised adults. In contrast to the centrilobular distribution of 3-in-bud nodularities, miliary TB is distinguished by its diffuse random distribution. Other highly perfused organs such as liver, spleen, bone marrow, adrenal glands, and kidneys may also be involved in miliary disease. Lymphadenopathy is also frequently seen in TB and is usually unilateral in 2/3 of cases, involving the right hilum and paratracheal region, but it can be bilateral in about 1/3 of cases. In some cases, lymphadenopathy may be the only radiologic finding, but it can be associated with ipsilateral parenchymal opacities, especially in the subpleural regions. On CT scan, lymph nodes, which are larger than 2 cm in diameter, may exhibit with hypodense centers with peripheral rim enhancement. TB lymphadenopathy may be complicated by obstructive consolidation, obstructive atelectasis, or hyperinflation due to compression of a bronchus by an enlarged lymph nodes. Perforation of a lymph node into a bronchus usually seen at the level of a right lobar bronchus or bronchus intermedius. The images show an example of a subcarinal lymph node seen on CT scan with central low attenuation which perforates into the right main bronchus. Associated right lower lobe consolidation and a minimal right pleural effusion are also seen. CT virtual bronchoscopy demonstrates the node protruding into the lumen of the right main bronchus. The corresponding bronchoscopy image is also shown. The last image shows the bronchus after cryoprobe removal of the lymph node. Lymphatic dissemination of TB is also a significant route of spread and could explain the resemblance between sarcoidosis and some cases of TB. Lymphatic dissemination can also explain why some cases with extensive lung involvement can test negative for sputum smears. Imaging findings may show clusters of tiny nodules with perilymphatic distribution. Subpleural nodules have additional clinical significance, especially in young male patients, because they are thought to be responsible for the development of paradoxical response, which is the expansion or new formation of a TB lesion with the immune reconstitution inflammatory syndrome during TB treatment. Pleural effusions may also be seen in TB and have been thought to be caused by breakdown of subpleural foci which release their contents into the pleural space directly or via pulmonary lymphatics. There is subsequent acute inflammation and exudation as a result of delayed hypersensitivity reaction to TB protein. Tuberculosis impaiima is typically loculated and associated with pleural thickening and enhancement, as shown in the image. Multifocal areas of paralymphatic nodularity and bilateral paratracheal and mediastinal lymphadenopathy are also seen. Some radiological features of TB may mimic those of other diseases in which they are initially described. These borrowed signs do not represent well-known characteristics of TB and may be considered an unusual appearance of perilymphatic micronodules. The reverse halo sign is described as a focal, rounded area of ground glass opacity surrounded by a more or less complete ring of consolidation. Similarly, the atal sign typically describes cases of cryptogenic organizing pneumonia. The COP is the most frequent cause of the reverse halo sign, but this appearance may also be seen in a variety of disease entities, including pulmonary tuberculosis. Patients with TB presents with a nodular pattern of reverse halo sign characterized by the presence of micronodules representing granulomas within the wall and inside the reverse halo. This morphological appearance of the ring and ground glass component with the presence of small nodules usually indicates active TB rather than organizing pneumonia. The galaxy sign describes a large parenchymal nodule that is formed by the coalescence of small nodules with multiple smaller surrounding satellite nodules. The cluster sign is also characterized by clusters of multiple small nodules, but the nodules do not tend to coalesce, in contrast to the galaxy sign. These imaging features were initially described in sarcoidosis but have been seen in cases of pulmonary tuberculosis. Establishing diagnosis and activity of Ptb is usually based on the detection of AFB in sputum smears or culture. The World Health Organization defines definitive sputum smear positive active in Ptb as 1 sputum smear examination positive for AFB plus a sputum culture positive for Mycobacterium tuberculosis, or 2 or more initial sputum smear examinations positive for AFB. The frequency of transmission in AFB positive patients was found to be 22% higher than that from patients with negative smears. Patients with sputum negative Ptb pose diagnostic challenges. Thus, it is important to note the following imaging features that has been shown to correlate with smear positive or negative samples. There is a significant correlation between radiologic extent of disease and the degree of smear positivity. The presence of cavitation, ground glass opacities, consolidation, nodules, and bronchial lesions significantly correlate with smear-positive Ptb and increase in AFB smear grade. Multiplicity of these findings in the upper lobes and the involvement of multiple lobes are associated with smear positivity. Cavitation represents an independent predictive factor of sputum smear positivity. Studies have found a significant correlation between mycobacterial load and both volume and number of cavities. Furthermore, the degree of smear positivity was found to significantly correlate with cavity wall thickness and distance from cavity to the nearest airway. The latter results from the fact that opening and discharging into airways is easier for central cavities than for peripheral cavities, which explains why patients with peripherally located cavities may be smear negative. Cavitation is also associated with a prolonged time required for smear to turn negative after 2 months of treatment. Meanwhile, centrilobular nodules may not be associated with sputum smear positivity due to the smaller volume of lung parenchymal affected and thus less AFB-rich exudation and necrotic material, and a longer distance to the central airway compared to consolidation and cavitation. Several studies have reported that galaxy sign and cluster signs correlate with smear-negative tests. Clusters of nodules were found to be positive predictor of initially smear-negative active Ptb. Reverse halo sign was found in several smear-negative cases of Ptb, probably due to a low incidence of cavitation in these cases. Thus, culture positivity is essential in the diagnosis of active Ptb in these patients. Further findings in smear-negative patients are consolidation in less than 2 lobes, absent cavitations, or just in a single pulmonary lobe, and presence of pleural effusion. In conclusion, we have discussed the classic findings of pulmonary tuberculosis, as well as the new concepts, particularly with regard to immune status of the patient, shared appearances from other diseases, and finally, the radiologic features which correlate with sputum smear positivity. Hopefully, the short lecture was able to serve as a helpful review and improve the diagnostic value of imaging in pulmonary tuberculosis. Thank you for your attention.
Thank you, Dr. Grace, for the extensive lectures about TB. Indeed, TB is a great mimicker for other diseases. May we ask for any questions? You can chat us in the chat box so I can direct it to Dr. Grace. Any questions from the group? Dr. Grace, parang ayaw na nilang mag-question. Naintindihan na nila lahat yung sa TB. Dr. Grace, ask ko lang, how do you tell it is stable na yung TB in chest X-ray alone?
Sorry, again.
How can you tell it if the lesion is stable in chest X-ray?
Findings in chest X-ray usually we can label it as stable if the lesion is consistent within 6 months period. No changes or noted within the 6-month period, so it is called already stable.
Okay, thank you. Kasi in our clinics, most of them are just requesting for the X-rays, no comparative. So how can you report if there's no comparison for the chest X-ray previous report? Can you tell it na you can compare for the previous, so you can tell the activity of the TB?
It's not safe to say the stability if you don't have any comparison. It is wise that you should request for a comparison from the previous study of the patient.
There is a question here. Is APLV, apical lordotic view, helpful?
I think so, yes. I'm not sure, but yes, I think it can help us.
Another question is, Doc, can we call active TB infection by CT scan alone? From Genobi Pogi. Pogi talaga.
Active, what is the question? Can we call
active TB infection by CT scan alone?
As we all know that Ptb is a great mimicker, so it can manifest different radiologic findings. The diagnostic what do you call this? The test for PTB is really the AFB sputum smear. So it should be coupled with the radiologic findings and the smear, not only the radiologic findings that you can call the TB as active PTB by CT
There
scan.
is another comment here from
No, it's not
James.
safe.
Thank you very much to a beautiful and ever graceful Dr. Grace Vargas. On CT, will it be easy to determine if the pulmonary nodules are due to TB or metastasis? If the patient has concomitant primary lung neoplasm, and if not, what is the next step for us in case PET?
Hello, Dr. James. Thank you for the generous comment. For your question, it will be easy to determine if the pulmonary nodule are due to PTB or metastasis, and if with concomitant no, sir. I think tissue correlation still would be the best to for us to tell whether the lesion is an infectious one or a neoplastic process.
How about PET now? Can you request for a PET?
I don't read PET. I'm not familiar. I'm not sure about that.
I cannot see any more questions from the chat box.
Findings of
another year. Medyo may humabol. What are the findings of active versus inactive TB?
Active versus inactive TB will depend on the status of the patient, if the patient is immunocompetent or immunocompromised. However, the basic findings usually you can see are the consolidations, the cavitations, and what else? Centrilobular or twin bud patterns. In inactive PTB, you can see the fibrotic changes or fibronodular changes, as well as the calcified or the non-calcified granulomas.
There is another question, pero same question din yun eh. Would like to ask, what would be the findings of active TB and versus inactive TB? I think Dr. Grace also answered that question. Any questions from the group? Maraming salamat. Thank you, James. Okay.
Go. Thank you, James, and thank you, Dr. Elepanio.
For our next speaker we'll talk about bronchial artery embolization on TB. May we call Dr. Marvin T. Tamanya. Marvin Tamanya finished his Doctor of Medicine at Manila Central University. He had his Master of Business Administration Health Program at Ateneo de Manila University Graduate School of Business. He had this training, residency training at the Philippine Heart Center, fellowship training in general ultrasound at Philippine Heart Center. He also had his fellowship training at CT MRI at the said hospitals. He had also his training in vascular and interventional radiology at Philippine Heart Center. She had also a training at Singapore General Hospital in interventional radiology training. Currently, he is a division head in Radiologic Sciences Division in Philippine Heart Center, concurrent heart head in section of interventional radiology at the Philippine Heart Center, past president at Ultrasound Society of the Philippines, current vice president of the Philippine Society of Vascular and Interventional Radiology, current board of examiner at the Philippine Board of Ultrasound, his hospital affiliation at the Philippine Heart Center, Veterans Memorial Medical Center, and the La Salle Medical Center. May we call Dr. Marvin Tamanya?
Hello, Dr. Ana. Thank you very much for the introduction. Medyo hindi lang updated, hindi na ako Board of Examiner of Ultrasound ngayon. I'm on the Philippine Board of Radiology.
Okay, sir.
Ayun.
I stand corrected. Yun ang binigay sa amin. Sige po, sir. Sorry.
Okay, so share my screen now. Okay, can you see the screen now?
Yes, doctor.
So, paano tanggalin yung nasa gilid? This time. Okay. So, good afternoon, everyone. So, I'm Dr. Marvin Tamanya. I'm a radiologist and a member of the Philippine Thoracic and Cardiovascular Radiology Society. So, I am tasked to discuss about bronchial artery embolization for hemoptysis in tuberculosis. I'm shipped. Okay, I have nothing to disclose pertaining to this lecture. I understand that the audience is quite diverse, so I try my best to make this lecture as simple as possible and understandable to everyone. So this is the outline of my lecture. In 2019, the Department of Health of the Philippines reported about 1 million Filipinos having active tuberculosis, and nearly 70 Filipinos die every day from this disease. With that data, the Philippines ranks fourth worldwide in the highest incidence of tuberculosis. Since March 2020, during the start of pandemic, there is disruption in regular TB services. At the end of that year, only 268,000 plus new and relapsed cases of TB were reported to DOH, and that is 35% lower as compared to the 2019 data. Despite of that, the Philippines still register highest number of incidents of tuberculosis in Asia, having 554 cases for every 100,000 Filipinos. The World Health Organization estimated that over 100,000 Filipinos will die of tuberculosis in the next 5 years. That is 20,000 TB deaths per year. Diagnosis of tuberculosis is based on symptomatology, imaging like chest X-ray and CT scan as discussed by Dr. Vargas, and of course, by laboratory examinations. Among the signs and symptoms of active tuberculosis, coughing up of blood or hemoptysis is the most dreaded and causes stigma of the disease. Hemoptysis is defined as a spitting of blood originating from the lungs and bronchial tree as a result of pulmonary and bronchial bleeding. It is classified into non-massive and massive hemoptysis. Non-massive comprises 95% of the cases and usually self-limiting, whereas massive hemoptysis comprises only 5% of the cases, but they are usually life-threatening and warrant urgent treatment. Massive hemoptysis definition varies in different studies or reports. It ranges from 100 ml to 1000 ml of expectorated blood in 24 hours. But the most widely used criterion is 300 to 600 ml of expectorated blood in 24 hours. Asphyxia is the most common cause of death, not exsanguination. An adult human airway can accommodate a volume of not more than 150 ml. However, even a small volume of blood can occlude the airway. Massive hemoptysis is a quantitative definition. It is better termed life-threatening hemoptysis if the patient is expectorating more than 100 ml of blood in 24 hours. The hemoptysis causes abnormal gas exchange or airway obstruction and causes hemodynamic instability. So nowadays, it is recommended that massive hemoptysis is better called as life-threatening hemoptysis. What causes hemoptysis? The cause of hemoptysis varies between Western and non-Western countries. The leading causes of hemoptysis in the Western countries includes bronchogenic carcinoma, chronic inflammatory lung disease, cystic fibrosis, and aspergillosis. Whereas in non-Western countries, tuberculosis and its sequelae are the most common cause. Puyanli et al. Reported that the overall cases of severe hemoptysis, 97% is due to tuberculosis. How does hemoptysis happen or occur? Remember, pulmonary system has a dual blood supply. The pulmonary artery that supplies almost 99% of blood supply supplies blood into the pulmonary parenchyma predominantly, whereas 1% is supplied by bronchial artery, which usually arises from the thoracic aorta. Although it supplies only 1%, the pressure is systemic and very high because it is coming directly from the aorta. In a diseased lung, particularly in chronic lung disease like pulmonary tuberculosis, there is hypoxia, vasoconstriction, vasculitis, and thrombosis of the pulmonary arteries, particularly at the level of the pulmonary arterioles. Those events result to reduce and eventual occlusion of the pulmonary circulation, resulting to bronchial artery proliferation, hypertrophy, in order to replace those occluded pulmonary arteries. That may result to rupture due to erosive effect of those offending agents. Simultaneously, chronic inflammation and neoplasm may trigger release of angiogenic growth factor in order to develop neovascularization. These new and minute vessels are very delicate and prone to rupture, leading to bronchial artery extravasation in the respiratory tree, resulting to massive hemoptysis. Diagnosis and management of hemoptysis usually starts with simple chest X-ray. It is basic and readily available, even in emergency cases. In this table, it is enumerated are the diagnostic clues on causes of hemoptysis as seen on chest radiograph. Take note that in tuberculosis, active tuberculosis in particular, the most common finding is cavitary lesion. So for those non-doctors, this is the appearance of cavity in chest X-ray. This is the appearance of cavity in CT scan. Although most commonly requested imaging examination, chest X-ray has only diagnostic sensitivity of 50%, meaning it can only diagnose 50% of the cases. The other 50%, chest X-ray will miss. Therefore, negative chest X-ray in a patient with hemoptysis should undergo other diagnostic study, like bronchoscopy. Again, bronchoscopy has low sensitivity that varies from 49 to 92% in localizing the source of bleeding. Diagnostic accuracy of bronchoscopy in patients with hemoptysis and with normal chest X-ray is very low, ranging from 0 to 31% only. Therefore, bronchoscopy should not be requested in patients with hemoptysis wherein the site of bleeding is unidentifiable or is identifiable in chest X-ray. Bronchoscopy has sensitivity of only 8% in detecting the cause of bleeding as compared to 77% of multi-detector CT. So, multi-detector CT is very, as compared to bronchoscopy, is very much sensitive as compared to bronchoscopy. CT scan, particularly multi-detector CT, should be performed prior to bronchoscopy in all patients with hemoptysis. It can suggest a specific diagnosis in 50% of cases wherein fiber optic bronchoscopy is non-diagnostic. It can also suggest a specific diagnosis in 39 to 88% of cases wherein chest X-ray is non-diagnostic. It can localize site of bleeding in 63 to 100% of cases. In multi-detector CT, it can identify bleeding bronchial arteries in 74% of cases. In contrast, it can only identify 11% of non-bleeding bronchial artery or normal bronchial arteries. In short, if you can identify bronchial arteries in multi-detector CT, likely you are dealing with abnormal bronchial artery. If you cannot identify bronchial artery in multi-detector CT, likely you are dealing with normal bronchial artery. So for those radiologists in the audience who are reading CT scan, it's very important to identify bronchial artery if your patient is having hemoptysis. So if in case the patient will undergo embolization, it will be a great help to us if you have mentioned or you have described what are the status of the bronchial arteries. CT scan and bronchoscopy are not competitive. They are complementary for assessing patients with hemoptysis. Bronchoscopy is useful in patients with hemoptysis with no detectable findings in multi-detector CT. Combined bronchoscopic and multi-detector CT findings provide more detailed information as compared to digital subtraction angiography. So, multi-detector CT of at least 64 slices has now replaced conventional catheter angiography in the evaluation of the aorta and its branches. Catheter angiography is now reserved for cases where endovascular treatment will be attempted. How do we manage massive hemoptysis? Well, it depends on the rate and sensitivity and severity of the bleeding and also clinical condition of the patient. Patient with hemoptysis can be managed conservatively. However, the mortality rate is as high as 50 to 100%. It is also not cost effective because the cost of treatment of conservatively managed patient is higher as compared to patients treated with embolization. The complication is also higher in conservatively treated patients. Surgery remains the treatment of choice once the bleeding site is established. However, majority of the patients with hemoptysis has comorbidity and poor pulmonary reserve, prohibiting emergency surgery. The mortality rate of emergency surgery in patients with hemoptysis is as high as 40%, as compared to only 7 to 18% in the mortality rate in general population. As I mentioned, 90% of the massive hemoptysis comes from bronchial artery with systemic arterial pressure. That is why immediate management, immediate uh, stoppage of the bleeding artery should be done. So surgery is out in those cases. Emergency surgery as initial treatment of choice is now limited in few selected cases like chest trauma and bleeding pulmonary artery. Embolotherapy or embolization recently is regarded as first line of treatment for massive hemoptysis. It is safe and most effective in almost all cases, particularly emergency cases. Effective embolization could be performed with the purpose of definitive treatment or bridging patient to stabilize the patient for elective surgery. A lot of studies prove that bronchial artery embolization is effective in the treatment of massive hemoptysis. Recently, there are also reports that it is also safe and effective in non-massive hemoptysis. How do we perform, or where do we perform bronchial artery embolization? So in this slide, I just want to show you a setup of a cardiovascular catheterization laboratory where we perform bronchial artery embolization. So this is the angiogram machine, this is the C-arm, this is the angio table, and these are the monitors where we can see in real time what we are doing inside the body of the patient. How do we perform bronchial artery embolization? As you can see in these images, we perform bronchial artery embolization in complete aseptic technique. So we perform it in full scrub. What are the materials needed? So we use Seldinger needle for puncture. We use vascular sheet, and we use different shapes of catheters and wires. How do we access the vessel? So we puncture the vessel. The most common vessel that we access is femoral artery. Nowadays, radial artery is also becoming popular. So upon puncture, we will insert a short guide wire. Through the guide wire, we will insert the vascular sheet, and through the vascular sheet, we will insert a long wire and direct it to the part of the body where we want to examine. And then through that wire, we will insert the catheter and go to the organ that we want to catheterize. I would, for this image, I would like to acknowledge Dr. Vincent Tatko. This is his animation when he was still a resident. Thank you very much, Dr. Tatko. And then after that, we insert the catheter for bronchial artery embolization. We go to the descending aorta, inject contrast media, like here. So this is an aortogram. Bronchial artery is here. So bronchial artery, once identified, we will super selectively catheterize using microcatheter. So this is now the bronchial artery of that patient. It looks normal. Once the abnormal bronchial artery is selectively catheterized, super selectively catheterized, we can now inject embolizing agent. So these are examples of embolizing agent. Among this, the polyvinyl alcohol is the most popular. Polyvinyl alcohol, or PVA, is a solidified form of alcohol. It is a permanent embolic agent. So these are sample images of bronchial artery embolization. Take note on the encircled part of the lung. So tortuous, and then hypervascular and neo vessels on this part. Once more. So this is prior to embolization. I hope you can recognize. After embolization, take note on this part, no more hypervascularity, no more neo vessels. Once more. Okay, so these are examples of injections before and after bronchial artery embolization. So how do we perform the procedure? Embolization of bronchial artery is based on the combined CT, bronchoscopic, and angiographic findings with clinical correlation. Normal bronchial artery in adult at its origin measures around 1.5 mm. And as it enters at the bronchopulmonary segment, it measures only around 0.5 mm. So, bronchial artery larger than 2 mm is likely abnormal. Again, for the audience, those who are reading CT scan, CT angiogram, it will be a great help to measure bronchial artery if you're able to identify it. Common findings or appearance of abnormal bronchial artery on CT scan and angiography are as follows. Dilated, as shown here, dilated and tortuous hypertrophic bronchial arteries, neovascularization and hypervascularity as compared to the normal bronchial artery on the right side. So, very obvious. Other findings may include shunting of contrast from the bronchial artery into the pulmonary artery or pulmonary vein. You can also identify in some cases bronchial artery aneurysm like this. The most sensitive and the most specific findings of bronchial artery or hemoptysis is contrast extravasation. However, it can be seen very seldom. The immediate success rate of bronchial artery and non-bronchial artery embolization is very good, to as high as 73 to 98% on the first day post-embolization up to 1 month. However, the long-term success rate is not favorable, meaning after 1 month, the recurrence rate is already high. What are the causes of failure or low long-term success rate of bronchial artery embolization? Number 1, it could be due to incomplete embolization due to proximal embolization. Like in this case, look at this. This is an abnormal bronchial artery with intralesional aneurysm here. Look at this. It was embolized proximally here at this level and at this level. So two proximal embolization will keep those distal abnormal bronchial arteries open, and it can recanalize through collaterals coming from the surrounding vessels. So it may cause recurrence. Another cause of low long-term success rate is uncontrolled cause of hemoptysis. This is very common in tuberculosis. In patients with tuberculosis and post-tuberculous sequelae, success rate of bronchial artery embolization decreases over years. It was reported that the 3-year recurrence rate, 3 years recurrence rate of 16.3% is the most recent statistics that was reported. It can be improved by repeated bronchial artery embolization. In some patients, it may take up to 3 sessions of bronchial artery embolization before we can totally stop the bleeding. Another cause of incomplete embolization is the wrong choice of embolic materials. In the early days of bronchial artery embolization, they are using gel foam, as shown here. This is the same gel foam that is being used in surgery to stop vascular leaking vessels. It is cheap and easy to handle. However, it resolves usually within a month, leading to recanalization of the embolized vessel. So now, we do not advise using gel foam alone. The most commonly used embolic agent at present is polyvinyl alcohol. As I mentioned, this is a solidified form of alcohol, which is a non-absorbable embolic agent. The most common or widely used size is 350 to 500 micra. Avoid using polyvinyl alcohol is smaller than 325 micra because that is the size of bronchopulmonary anastomosis. If this PBA will be able to pass this anastomosis, it may result to pulmonary infarction. So the safe size is 350 to 500 micra. Liquid embolics. Early reports of bronchial artery embolization discourage the use of liquid embolics due to association of high risk of severe complication. However, current report says that it is effective uh, in stopping the bleeding of bronchial artery. 1 month follow-up non-recurrence rate is as high as 88.8% and as high as 80.5% in 1 year follow-up. So this is much better as compared to PBA. However, the disadvantage is that it is difficult to control. So the risk of embolizing non-targeted vessel is very high. There is now a newer form of liquid embolics. We call it onyx. It is safer than the earlier NCBA, but the major disadvantage is that it is very, very expensive. And also, its diluent, the DMSO, its diluent DMSO is vasotoxic. What about the use of coil? Generally, we do not recommend coil for bronchial artery embolization because it can just cause proximal occlusion. As I mentioned, proximal occlusion is associated with higher incidence of recurrence. So now we use it. For in cases only in cases wherein there is pulmonary artery aneurysm, or in instances wherein we want to prevent occlusion of the normal vascular territory. So if you occlude proximally, it can the distal end can recanalize through collaterals. Another factor in the success rate of bronchial artery embolization is the operator's knowledge of bronchial anatomy. 90% of hemoptysis, as I mentioned, is coming from the bronchial artery, which has systemic pressure. More than 70% of the bronchial artery arises from the descending aorta at the level of T5 and T6, or at the level of the carina, as shown in this image. So again, for those performing interventional procedures and those reading CT aortogram, I think this you should remember this. T5, T6, or level of the carina. Up to 20% of the bronchial artery have an aberrant origin. Caldwell has a very good classification of bronchial artery branching as enumerated here. So for those, again, for those reading CT and doing interventional radiology, I think this is again very important. So it is very important to include this in your report. The operator must also be knowledgeable of the possibility of involvement of non-bronchial systemic arteries. Missing these arteries may result to persistent bleeding. So, involvement of non-bronchial systemic artery is common in patients with pleural involvement. If the pleural thickness is 3 mm or thicker, likely there is non-bronchial systemic artery involved. So again, for those reading CT, for us IR, it is very important if you will report the thickness of the pleura. Most common non-bronchial systemic arteries that are involved in hemoptysis are as follows: intercostal artery, branches of the subclavian and axillary arteries, internal mammary artery, and inferior phrenic artery. What about recurrence of hemoptysis after successful bronchial artery embolization? Recurrence is lower in active tuberculosis receiving treatment. It is attributed to the protective effect of anti-TB drugs. One report that recurrence rate of hemoptysis in chronic tuberculosis is as high as 15.5%. So again, those patients with active TB taking anti-TB drugs is more protected from hemoptysis as compared to those patients having hemoptysis due to TB sequelae or having chronic tuberculosis. What are the risk factors that there will be recurrence that promotes recurrence of hemoptysis after successful bronchial artery embolization? Number one, ongoing hemoptysis 7 days after the bronchial artery embolization. Those patients receiving blood transfusion and those patients that has aspergilloma and, of course, tuberculosis. Presence of only one risk factor is usually non-fatal. However, presence of at least two of these risk factors is associated with fatality rate of as high as 31%. Radiologic and angiographic appearance are not predictors of possible recurrence. Mortality is higher in patients with recurrence with, as I mentioned, as high as 31% as compared to mortality of non-recurrence of only 10%. Bronchial artery embolization is not 100% safe procedure. Of course, there are possible complications. That is why thorough knowledge of bronchial anatomy is very important prior to bronchial artery embolization, because bronchial artery may not just supply the airways, but also supplies other surrounding or adjacent structures. For that reason, CT aortogram prior to embolization can provide important information to prevent inadvertent embolization of those structures. The most common complication reported by patients is chest pain. This is usually transient and attributed to ischemic phenomenon of embolization. Dysphagia is also common. This is due to embolization of the esophageal branches of the bronchial artery. But luckily, it regresses spontaneously. Subintimal dissection may embolization. The most dreaded and feared of complication of bronchial artery embolization is occlusion of the anterior medullary artery known as Adamkiewicz artery. So, take note of this. This hairpin-shaped artery, this is the Adamkiewicz artery. Occlusion of this artery may lead to paralysis of the lower half of the body. So, be cautious, be careful not to occlude Adamkiewicz artery. Other rare complications are as follows. Take-home points. Tuberculosis is the leading cause of life-threatening hemoptysis in non-Western countries, including Philippines. All patients with hemoptysis should undergo multi-detector CT scanning prior to embolization, because embolization now is treated or considered as the first line of treatment for life-threatening hemoptysis. It could be done either as definitive treatment or as a bridge to stabilize patient prior to surgery. Bronchial artery embolization is safe and effective for both massive and non-massive hemoptysis in tuberculosis patients. Knowledge of the arterial anatomy and uncontrolled cause of hemoptysis are the major causes of hemoptysis recurrence, embolization failure, and occurrence of complication. This is my last slide. Thank you very much.
Thank you, Dr. Tamanya, for sharing your expertise. May I ask for any questions from the group? You just chat us in a chat box so we can address to Dr. Tamanya. Parang Doc, parang natakot na sila magtanong sa'yo.
Wala nang question?
Doc, may tanong lang ako. How much
Okay.
yung procedure, Doctor?
OMG. Alam mo, sometimes that question stops the bleeding. Actually, here in our institution in Philippine Heart Center, we are a bit lower, most likely, because this is a government hospital. But in our setting, we usually ask the patient to prepare at depending on the material that we are going to use. For example, if we will just be using PBA, one vial of PBA costs only 5,000. And usually in one patient, we can use just 1 or 2 vials. So I think 100,000 or 150,000 is enough. But if we are going to use liquid embolics, particularly Onyx, Onyx itself will cost around 118,000 for one vial, one diluent, and one microcatheter. So it varies depending on how on what embolic agent are we going to use.
Okay, Doctor. There are some questions here, Dr. Tomania. Up to what micron size can we use for PVA?
Actually, the largest that we are using is 500 to 700 micra. That is the size on our stocks. But the most commonly used is 355 to 500.
Okay. Another question here. How do we refer patients to you, Doctor?
Well, you can just call me or send patient to what center. By the way, ang isa sa sigurong pwedeng maitulong ko sa mga pasyente, Philippine Heart Center is a government hospital, and a lot of politicians, a lot of government organizations have funds here. So for those patients who cannot afford those private institutions, but still needing this type of technology, this type of treatment, we can accommodate them, provided they are willing to process those guarantee letters.
Okay, Doctor. Another question here is from Dr. Imar. Is there a role for RBC tagging in nuclear medicine for hemoptysis if negative CT scan?
Usually, we don't need that because patient is expectorating gross blood usually. So, no, because RBC tagging is recommended only for those occult blood. So, this patient usually come to you, matatakot ka kasi minsan papakita nila sa iyo sa tabo nakalagay or sa baso puno ng blood. So, no need for RBC tagging most of the time. And yun nga, sometimes negative ang CT scan, negative all imaging, but upon injection, abnormal ang mga bronchial and some systemic non-bronchial collaterals.
Okay, thank you. Anna, there's no more question in the chat box. Meron pa po.
I
Okay,
think nasa,
Dr.
I think nasa audience yung mga IR fellows natin, the residents. I think this is the time you can ask for about the procedure. So especially the So no more question.
Parang wala na, Doctor eh.
Okay, so kung wala nang question, thank you very much. Thank you to Dr. Roy Vizcara. Thank you to Dr. James, Dr. Imar, and to Dr. Anna. To everybody, good afternoon po. Salamat.
Thank you din, Doctor, for sharing your expertise to us. And for the last part of our webinar is, can we ask Dr. Roy Vizcara, the President of the Philippine Thoracic and Cardiovascular. Oh, okay. Sorry, we have to give us a certificate of appreciation. So, Philippine College of Radiology and Philippine Thoracic of Cardiovascular Radiology Society presents this certificate of appreciation to Mary Grace D. Vargas for her active participation as lecturer during the Pcr Connect celebrates the World TB Tuberculosis Day for 2022, entitled A Glimpse of Radiology in Action from Diagnostic Therapeutic, awarded this at the 24th day of March 2022 via Zoom webinar platform, signed by our President, Dr. Ingmar Elipanyo, Christine Susan Sagpao, our PCR Secretary, and the President of the PTCVR, Dr. Roy Vizcarra. Same to Dr. Tamanya. This is a certificate of appreciation to Marvin D. Tamanya for his active participation as lecturer during the Pcr Connect celebrates the World TB Day for 2022 entitled A Glimpse of Radiology in Action from Diagnostic to Therapeutic, given at the 24th day of March 2022 via Zoom webinar platform, signed by our President, Dr. Imop, our PCR Secretary, Dr. Christine Sagbao, and the President of the PTCVRRS, Dr. Roy Vizcarra. Thank you, Doctor. So may we ask Dr. Roy Vizcarra to give us our closing remarks.
In behalf of all the officers and members of the Philippine Thoracic and Cardiovascular Radiology Society, I'd like to thank everyone for your attendance, most especially the president of the Philippine College of Radiology and all the officers of PCR, headed by Dr. Elepanio. I'd also like to thank Dr. Agabao for doing a good job as PhilCat representative, and most especially the two speakers. Dr. Tamanya, thank you so much. You made our day special today. As radiologists, you know, we're always being told that we're just diagnostic, but with you on our side, it becomes special because the therapeutic part is there. And your therapeutic intervention is not just, you know, similar to everyone else. It is actually life-saving. I've seen one case, a patient who practically exsanguinated, you know, bled to death because of pulmonary tuberculosis bleeding. I know if you're around, you'll be able to stop that bleeding, and, you know, most likely he will still be alive until now. And for Dr. Vargas, thank you for being an excellent speaker. You know, tuberculosis, the topic is so mundane, or it's so common. It feels like everybody knows tuberculosis already. But after your lecture, you made it very special in terms of, you know, making it interesting, differentiating, you know, active from inactive tuberculosis, the sputum presentation, and comparing it with the CT scan findings and the X-ray findings. These are all very special for us. And what's good is that what you have taught us today is applicable in our daily practice. Thank you for all the pointers, Dr. Tamanya, for all those, you know, nuggets you gave us regarding the measurement of the bronchial arteries and where is it coming from T5, T6, and along the carina. I will always remember that, and I will always look for the bronchial arteries and try to measure it. And also for Dr. Grace, thank you for all the pointers that you know, not all 3 invalidopathies would signify active infection. Thank you so much, everyone, for your attendance. This day will not be complete and it will not be special without all of you. Thank you, everyone. Have a nice day.
Thank you. Thank you for all the attendees. I hope you learned something new. Bye.
Thank you very much, Dr. Ana, Dr. Roy. Thank you very much. Dr. Marvin Tamanya, Dr. Grace Vargas, thank you very much. Ingat po always.
Ingat din po kayo, sir. Thank you din.